Good morning, everyone. My name is Robert Hersey. Happy Tuesday to each of you. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Grassroots Development of Peer Recovery Support to Address the Opioid Crisis in Rural Communities. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to the presenter and myself, the host, FATA Webinars, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. One of these options is on the screen now, and all options are posted in the chat panel too. After ensuring that your volume, both on your computer and speakers, if applicable, is not lowered, you may click the Communicate menu, then click the Audio Connection panel. Click Disconnect, follow the first two steps again, then click Call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are on your screen and in the chat panel. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. We are unable to verify attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, your web browser will direct you to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Please ensure that your name and email address match your webinar attendance. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Friday, March 29th, 2024. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing your account or the survey, please fill out a contact form at www.fata.org or email training@floridabha.org before the evaluation closes. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Now I'd like to introduce our presenter for today. Our presenter is Shaina Bradley. Shaina Bradley is Director of Peer Recovery Services at Davies Community Hospital in Washington, Indiana. With over 10 years of experience in both healthcare and criminal justice settings, she currently implements hospital recovery support services in conjunction with the County Mobile Integrated Response System. Shaina also managed the Davies County State Opioid Response Grant for 3 years. She graduated from the University of Southern Indiana with a bachelor's degree in social work with a concentration in substance abuse counseling and a master of social work, specializing in mental health and addiction. Now, Shaina, I will turn it over to you.
Thank you, Robert, and good morning, everybody. My name is Shaina Bradley, and today I'll be presenting a webinar over the grassroots development of peer recovery support to address the opioid crisis in rural communities. So this morning, we're going to take a look at the different challenges of addressing substance use in rural areas as well as versus urban areas. We'll take a look at the risk factors associated with substance use in rural communities. We will discuss and learn how to tailor substance use interventions to more effectively address the needs and situations of communities and areas. And we will also develop an understanding of the Sequential Intercept Model, also known as the SIM model, with strategies and examples of what success looks like within each step. Substance use is everywhere. The prevalence of substance use, it can vary between rural and urban areas, and it can depend on the type of substances that are being considered. In some cases, rural areas have been reported to have higher rates of substance use, such as prescription opioid use and methamphetamine use. Factors like limited access to healthcare, economic challenges, and social isolation can also contribute to substance use in rural communities. On the other hand, in urban communities, there is a higher overall rates of substance use due to factors of greater accessibility and availability of drugs, the higher population densities, and the increased social pressures one can feel in urban areas. Urban environments can also be associated with higher rates of alcohol and marijuana use. Some nationwide data we have, 40.3 million people in the United States have had a substance use disorder in 2020. And about 2021, about 107,000 people have died from drug overdoses. Through reported, Black and American Indian, Alaskan Native people have had the highest rates of fatal overdoses in 2021. To kind of kick off here, I have a discussion question that we can look at and seeing how have the overdose rates, death rates changed in the United States from 2011 to 2021. In the chat, if you would like to answer, also looking at which state has had a higher total of overdose deaths, Florida or Indiana. If you'd like to answer in the chat of if your thoughts if they have increased, decreased, or remained stagnant, and which state has also had a higher chance of overdoses. I'll give about a minute here for everyone to throw their answers in the chat. Definitely looking through the chat, it seems that Florida has been a top response, as well as Indiana. And we'll kind of jump ahead to the next one here. And if you look at the stats from 2011 to 2021, Florida has had an increase of 37.5 to the United States average of 32.4% deaths in the United States. And then also in comparison to Indiana, Indiana had 43% drug overdose deaths compared to Florida's of 37. So it looks that Indiana has had a higher percentage of overdose deaths in 2011 to 21 compared to Florida. And jumping ahead, looking at this as well as an age-adjusted death rate of opioid overdose in Florida versus Indiana. If there is a common trend of a common trend of opioid overdose in Florida versus Indiana. If there is an age adjusted, we can answer in the chat here. I'll leave a minute to do so. So it looks like we have some varying answers from in the 20s to 30s. It looks like 30 is a common trend, 20 to 30. I'll give a few more seconds here to get your answers in. All right, and then if you take a look at this slide here, in 2021, there were 5,940 opioid overdoses in the state of Florida, which accounted for 76% of all drug overdoses in the state. Across the United States, the opioid overdoses accounted for 75% of all drug overdoses in the country for 2021. Looking at age-adjusted rates for opioids, there was an increase of 8.4 per 100,000 to 28.9 per 100,000 individuals in Florida. On the same period, the adjusted rate increased from 7.3 per 100,000 in the United States to 24.7 per 100,000 in the United States. When you jump to looking at the state of Indiana, there was 2,206 opioid overdose deaths in Indiana, which accounted for 78% of all drug overdose deaths in the states. This was an increase from 5.6 per 100,000 to 34.2 per 100,000 in the state of Indiana. So within the answers in Indiana, it looked as we had 34.2, and for Florida had a lower age average of 28.9. So as we can see, it was a younger age located in Florida versus Indiana, a little bit of higher age gap of 34 years of age of a change. An important note, though, is that substance use disorder and substance use is a very complex issue, and it is influenced by a variety of factors and rates that can widely depend on the specific location and populations that we are studying. For a majority of this webinar presentation, most data will compare to Indiana and Florida as well. In looking and identifying urban and rural communities, according to the U.S. Census Bureau, 80% of the United States population lives in urban areas. The remaining 20% live in areas classified as rural. There isn't a specific category currently for suburban areas, as there is emerging data to look through. The urban population includes people who live in urban clusters, populations between 5,000 and 50,000, and urban areas which have more of 50,000 people plus. Defining the U.S. Census Bureau defines rural as anything not urban and includes all localities with a small population, less than 10,000 individuals, located outside of an urban cluster area. This broad definition can inadvertently come to include different types of locations, such as densely small towns, exurban pockets, frontier areas comprising of fewer than 6 people per square mile. The remote, sparsely populated areas is often described as rural communities. Taking a look at rural America, about 60 million people, or 1 in 5 Americans, are living in rural America. Rural areas are generally sparsely populated, having low housing density, and are from urban centers. Urban areas comprise of only 3% of the country's entire land area, but they are home to more than 80% of our population. 97% of the country's landmass is rural, but only 19.3% of the population lives there. Taking a look into rural communities, there are varying characteristics, and in rural areas, they are sparsely populated areas with low low population density, characterized by open spaces, farmland, and natural landscapes. As well as in rural communities, there is limited access to services and amenities, including healthcare, education, recreational facilities, and transportation. Rural lifestyles are often characterized by a closer connection to nature, a slower pace of living, and a stronger sense of community. There is a strong sense of family connection and ties as well in rural communities. Economic activities in rural areas are often centered around agriculture, forestry, mining, and small-scale industries. Taking a look at the differences between urban and rural areas is there's many factors. Taking a look into population density, urban areas are characterized by higher population density, while rural areas often have lower population density and are more spread out. Throughout infrastructure, urban areas are typically more developed in comparison to rural areas, and they also have better access to healthcare, education, and transportation. Economic opportunities in urban areas, they are generally more diverse and have more opportunities compared to rural communities. And this can also impact significantly the employment rates and income levels of the availabilities of jobs as well as the specialties. Looking at the social environment, urban areas tend to have more diverse and dynamic social environments, as with a greater variety of cultural and recreational activities compared to often more close-knit and traditional areas in rural communities. In urban areas, you can tend to find different activities available to individuals, more opportunities in comparison to rural areas. A big factor is access to service. Urban areas typically have better access such as healthcare, education, and entertainment, while in a rural setting, these can be limited. Where I am located at, access to service is a big barrier for many needs. More often than not, we're traveling a minimum of 45 minutes to 60 minutes to get standard clinical care or mental health care as a need versus urban areas. You might be able to travel 5, 10, 20 minutes to get services. Another difference is the cost of living. Often in urban areas, the cost of living is much more higher compared to higher housing costs, as well as other expenses you can find living in urban areas compared to rural, where the cost of living can be much lower. There are environmental factors that do play into both areas. Rural areas often have more natural and open spaces, while rural areas tend to have more pollution and noise due to higher levels of industrial and vehicular activity. In rural areas, you can find more farming land being taking place in comparison. In the communities, there's social supports where it's tend to find that rural communities have stronger community ties and social network supports compared to urban areas, which can impact one's mental health and well-being. Individuals have reported feeling more isolated compared to into urban areas versus rural areas. But overall, urban and rural areas often differ in their lifestyles and opportunities, each that have their own advantages and their own challenges. Even though there's differences, there's also similarities. Roughly equal shares of urban and rural area residents say that substance misuse is a major problem in their local community. As I'm sure all of us on this webinar, as we work in various settings, substance use can be found throughout the world. No matter where we live, substance use is everywhere. When it comes to the availability of jobs, rural adults often somewhat feel to say that this can be a problem where they live. 42% have reported saying so, as a substantial share of individuals living in urban areas compared to say 34% say the same, and a higher share that in suburban communities. There are additionally other problems that present in both areas, such as access to affordable housing in cities, access to public transportation are felt more in rural areas than in cities. Cities and urban areas may have more forms of access of public transportation, but they're compared into rural areas where they may have very minimal to no access of public transportation services. About 4 in 10 U.S. adults that live in the community that live in or near the community that they grew up. Half of residents that live in rural areas, about 47%, say that they live in or near the community where they grew up, which is about a quarter, 26% of adults who say that they have always lived there. Among those that live in an urban and suburban area, about 4 in 10 say that they currently live in the community of where they have grown up. 42% and 38% respectively, which in 1 in 5 saying that has always been the case. With both areas, family concerns can tie into as a benefit and as into a barrier for many. More residents point to having family ties as factors as to one of the main reasons they have stayed in the community of where they have grown up, left, or later returned. For many individuals, they stay there for having the support of having family members to provide childcare access, to help out when in need, and also to help provide support and raise families. Having that family connection is a big is a big potential factor for those to succeed, being able to have the support locally of where they live. About 4 in 10 adults who have left and came back to their home areas, those 42%. 35% of those who have lived in or near the same community say that they have done so to be near family. About half of adults that have lived in or near the community they have grown up in, 52% of those adults also say that most of their extended family members live within an hour's drive from them. Being someone that lives in a rural area, I can attest to this, that almost all of my family is within a 30-minute drive of where I'm at. I'm an individual that fits into that little niche of staying in the community of where they have lived. Having a family connection can be a strong benefit to excelling not only in your family, but also within your academics, of having that social support near you as you're trying to advance and grow within your own roles. The majority of Americans that live in urban areas, as a 68% and 59% suburban, with 62% in rural communities, say that they do not currently have enough income to lead the kind of life they want to live. 63% of adults in rural areas who say that they do not have currently enough income to where they would like to live, to lead the kind of life they would like to live, do not expect to in the future, while 36% think that eventually they will. I'm sure that with today, those stats would also be quite higher of individuals reporting they do not feel that they have enough income they want to live. That is a barrier we can find in urban settings as well as in rural settings. Looking in rural areas, there's many risk factors that one can look at that can affect one's risk to develop substance use disorder or to experience substance misuse. There is limited access to care. Rural areas often are found to have fewer healthcare resources, including addiction treatment facilities, mental health services, making it harder for individuals to seek help. In isolation, as we said earlier, rural communities tend to be spread out, more diverse, more land, and with that, one can feel greater social isolation, which these can lead into further feelings of hopelessness, loneliness, or depression, and can increase the risk of substance use as a coping mechanism for those found in rural areas. Economic factors that play into role is poverty and the lack of economic opportunities to one living in a rural area. These can contribute to substance use, as individuals may turn to drugs and alcohol as a way to cope with stress and or hopelessness. Stigma around substance use is prevalent through rural and urban areas. In rural communities, they may feel a stronger sense of stigma surrounding mental health and addiction, which can prevent individuals from seeking help or talking openly about their struggles. Stigma can play into effect in rural areas for a major reason of being in smaller communities. Most oftentimes, those that they see in working settings may be those that they went to school with or those that are their family. In rural areas, you tend to know everybody. It's a small community. So if they're going to seek mental health services, they might end up seeking services from someone that they know, so they could feel stigma of reaching out for help, therefore delaying them into getting help. With that as well, being in rural areas, access to care is also a risk factor. Throughout the United States, some rural areas may have a higher availability to access to care, as that is increasingly happening in more services. However, with that, there is also an increase of access to availability of drugs in the areas. In rural areas, as well as in ours, prescription opioids and methamphetamines are the top substances that you can find that are have an easier access to in rural areas. An additional risk factor that we can look at is their cultural norms. In rural communities, those might include the acceptance or normalization of substance use. Sometimes you might hear individuals, well, their whole family is in addiction. Their whole family, that's just how they are. In rural areas, this can also be found in urban areas as well too. However, with the cultural norms, it can make it more likely for individuals to engage in those risky behaviors. In addition, a lack of awareness, having limited access to education and information about the risk of substance use can also greatly contribute to the higher rates of drug and alcohol abuse. In rural communities, prevention is key to really helping those get awareness. You don't know what you don't know, so education is huge on not educating only the youth, but the adults and the entire families of the substance, of the signs, the symptoms, and what to be aware of to help those later on down the road prevent substance misuse. In addition, environmental factors do play as a risk factor in rural areas, such as living with higher levels of stress or trauma. This could be if they're living in an area that has been impacted by natural disasters or economic downturns. This can increase the risk of substance use. And it is important to be able to address all risk factors through comprehensive prevention treatment strategies, whether it is engaging at the community level, at the individual level, or through as the whole systems to address substance use. Taking a look at urban America and comparing into rural America, there are vast differences and similarities. In urban America, urban communities, you can find a higher population density. You'll find more individuals living in an area of urban settings as there's more advanced housing, more industrialized services, and infrastructure. In addition, higher concentration of buildings, you might see more skyscrapers, more space, as well as transportation and commercial activities. There's a wide range of services and amenities that are offered in urban areas compared to rural settings. In an urban area, you might be able to find 5 different forms of public transportation or 5 different mental health office settings, substance use detox facilities, all within this area. Compared to a rural area, they may not have detox services or mental health services available in that community. In urban areas, it's more known to have high, fast-paced living, people moving, always on the go from point A to point B quite fast. As well as in urban areas, it's reported higher levels of noise, pollution. As mentioned, individuals are always on the go, going to work, traveling. With that is a lot of pollution from vehicles, exhaust that comes out. And when you look at urban areas, there are risk factors that are similar into rural areas, but they play a different factor. With urban areas, there is a higher access to and availability of drugs. In urban areas tend to have a higher population density, making more extensive drug distribution networks available. In urban areas, you might have bigger scenes of where drugs are getting distributed out. And so with that, there's more access, with more individuals being around that have the means to get those or to distribute out. In addition, in urban areas, this can also be tagged as a risk factor for rural areas is peer pressure. There tends to be found to have higher levels of peer pressure in urban areas, leading individuals to use substances to fit in with their friends or to socialize. In the urban settings, a big substance, alcohol, can be found, as many today see alcohol as a social norm. If you go out to a restaurant, many will order a drink, or there's bars. Drinking has become in urban areas and as well as rural as kind of a social norm. Individuals will go out to get a drink, and so many have found that as well, it's normal. Everyone's going out to drink, so if they're drinking, then I can drink too. And so peer pressure in urban areas can be found very much higher than in urban areas. In addition, you can find higher levels of stress and higher mental health concerns for individuals living in urban areas compared to rural areas. This causes This can be associated with higher levels of stress, higher levels of anxiety, and mental health issues, which can increase the individual's use to using substances. Socioeconomic factors play a role as a risk factor in urban areas. They have a higher rates of poverty levels, unemployment, and economic disparities, which can contribute to substance use in individuals. Many individuals in urban areas tend to have high stress due to higher cost of living, higher risk of finding jobs, and many turn to substance use as a coping mechanism. Access to treatment. Even though urban areas have more availability of services ranging from detox, mental health, substance use, there is the access that still plays a significant risk factor in urban areas. Even though they have more resources, there can still be significant barriers for one to addressing treatment, such as the cost, transportation, and stigma. Stigma is prevalent through all communities of addressing mental health and substance use concerns. In addition, cultural norms are also a risk factor in urban areas, such as the acceptance and normalization of substance use. As we mentioned, in rural areas, sometimes there's individuals may say, well, a family, that's their norm, that's what they do. As drinking has slowly, for many, we can see, has been tried to be a social norm, many might write that off as it's just what everyone does. They write that off as their attitudes, behaviors, beliefs, and normalize it. So some may find that that is exposure increasing the normality to substance use. With that, the media, social media, and advertising in urban areas plays a significant risk factor. Those that live in urban areas often are exposed to more media, to more advertising that can glamorize or promote substance use. With that, it can significantly influence young adults. In my area, as caffeines, energy drinks, I'm seeing that more often as being advertised and marketed. And for even in rural areas, energy drinks, sometimes those ads are targeting younger age groups. So what they're seeing on social media, what they see on YouTube, what the celebrities they follow, what they're advertising plays a huge factor into how it impacts one's substance use. And an additional risk factor is social disconnection. Even in urban areas, there is a higher population. Urban areas can also have social isolation, leading individuals to substance use as a way to help coping with this. And by addressing all of these factors, it takes a multifaceted approach that includes prevention and early intervention and access to treatment options to help combat substance misuse in urban areas. In addressing substance use, there are a multitude of barriers. We can jump in looking at both. We will do a comparison of rural and urban areas, but just know that in addressing substance misuse, these barriers will be found in both areas. Each community has their positives of being able to address it, but barriers will remain the same, look a little different in each community. Taking a look at access to treatment, as we mentioned, rural areas often have fewer healthcare resources, including addiction treatment facilities, detox facilities, and mental health services, thus making it very, very more difficult for individuals to seek help. For example, community that I live in is a very rural community, and our closest detox facility is an hour away. Our residential substance use treatment is about 45 minutes away, and our specialized addiction treatment is about 30 minutes away. We're slowly expanding, and the services are now here in the area, but even where I live, it's a significant barrier. And with that, transportation, 8 out of 10 times rolls into that of we can get individuals there, but how do I get back home? If I want to go help get detox, how do I get myself back? And that is a big barrier we're seeing. As well as social support. Rural communities, we tend to have higher tight-knit social networks. There's always, rural areas, everyone knows everyone. Sometimes that's a blessing, sometimes that's not a blessing. In addressing substance use, knowing everyone can also lead into the stigma. This can help provide support for individuals trying to enter recovery, but this can also provide stigma and reluctance for individuals to seek help. As shared, if an individual goes into the hospital setting, the nurse could be their classmate, could be their friend they grew up with, or their family member. And so going to seek help from those you personally know can also be a barrier to wanting to get help, of feeling stigmatized of what will they think of me, or who's going to know that I was here. That can really push individuals to not seeking help. In addition, economic factors also is a big barrier to addressing substance use. The poverty and lack of economic opportunities for individuals can contribute in both substance and in rural areas. Specific economic challenges do vary. Many individuals have an economic challenge is having the insurance in order to get into treatment, or being able to pay for treatment services ongoing, aftercare or continued care. So we see barriers with individuals of having limited access through their insurance providers, or not having the access because they're not sure of how to start to navigate to get their treatment. In addition, the availability of certain drugs does play as a barrier. Urban areas tend to have more access into drugs, whilst rural areas tend access to specific, not as more varied drugs, but this can have higher rates of substance use and impact the individuals seeking to get help. In addition, the norms around substance use in urban and rural areas, this can influence one's behaviors and beliefs towards substance use. This can be the same and vary in urban and rural areas. The norms of substance misuse can impact if their friends are using that, and that's what they've known. They have not been shown a route of what's different or what the opportunities are there. So big pieces, people, places, and things of the norms you're hanging out with, and seeing of who in your circle is impacted by substance use. And in addition, social isolation. While rural areas also experience greater social isolation, urban areas tend to have isolation due to factors of higher population density, transient populations, and this also impacts substance use. By being able to understand these differences in urban and rural areas, we can look at developing effective prevention and treatment strategies tailored to the specific needs of urban and rural areas. And addressing substance use in both areas, a model that we will take a look at is the Sequential Intercept Model. The Sequential Intercept Model, otherwise known as the SIM model, is an effective evidence-based model that communities can implement to address the behavioral health and substance use treatment needs of their residents. As I stated earlier, urban and rural areas will have differences in connecting and tailoring needs to those that they are serving. The SIM model has 5 intercepts, which starts at intercept 0, leading all the way up to intercept 5, of different ways of integrating and implementing services to help those that are needing mental health and substance use get connected into services. Taking a look into the SIM model details how individuals with mental health and substance use disorders come into contact and move throughout the criminal justice system. The model can help communities identify resources and gaps in services at each intercept and develop local strategic action plans. The SIM mapping process brings together leaders and those at different agencies and systems to work alongside each other and together to help identify strategies in diverting people with mental health and substance use away from the justice system and into treatment. And working in the substance use field, more often than not, over majority of our clients' population are justice involved. And the SIM model is helping trying to break that down so individuals do not necessarily have to go through the criminal justice system in order to achieve recovery and reach these services. As being located in a rural community, many, even growing up, were unsure of how to get help, falling back into the stigma around substance use. Many feel that I don't need to see someone unless I have something severely wrong with me. Many have used the term shrink before for therapy, or that they feel that they have to have something catastrophic happen for them to have to seek mental health services. The SIM model has brought that brought forward to help prevent individuals from entering the justice system to seek the mental health or substance use services they need prior. Of looking at implementing the SIM model in rural communities, the SIM model can help mitigate risk factors experienced by individuals in rural communities, such as unemployment, the lack of access to mental health services, social isolation. Substance misuse in rural communities possesses unique challenges compared to cities and urban areas. Taking a look at rural communities, the overdose rates in rural counties had increased from 4.0 to 19.6 per 100,000 people between 1999 and 2019. Per capita, the opioid overdose rate in rural communities is 45% higher than it is in cities. Around 14% of behavioral health treatment facilities in the United States are in rural communities, and less than half of these specialize in addiction treatment. And so the need for having addiction specialized treatment services is very prominent in rural communities, as well as having behavioral health services in rural communities alone. In the area that I live in and have lived in for 20 years, addiction treatment was not really talked about until these last 4 or 5 years. With myself being an addiction specialized social worker and clinical addiction counselor, it's still new. And so advocacy is huge in our roles of getting the services for those that we are living in and serving. Taking a better look at the SIM model photo, as I mentioned earlier, the sequential intercept model does have 5 intercepts. Intercept 0 starts at community services, and then leads into intercept 1 of law enforcement. You transition into the second intercept of initial detention, initial court hearings, transition to intercept 3, which consists of our jails and our court settings, intercept 4, our reentry services, and intercept 5, back into community services. And so if you take a look at this table here provided by SAMHSA, some examples of each services for intercepts are provided. For the first intercept, it recommends crisis lines, which can also be tied into the 911 or 211 in our area to help connect two services to talk to, if someone is in crisis, to talk to someone. In addition, that can also go through to crisis care continuum, or it can lead into intercept 1, which involves law enforcement services. From there, that can start with 911, local law enforcement engaging with individuals, and that is at intercept 1. When you transition into intercept 2, you're looking at the initial detention, initial court hearings. Individuals will attend their first court appearance. And moving forward to 3, there's specialty courts. Some areas have drug courts, recovery courts, or family courts. There is also the jail or dispositional courts that can be offered in areas to help individuals addressing their substance and mental health use. In addition, when you transition into intercept 4, we're looking at reentry. This can be prison reentry, jail reentry, and this can be reentering back into the community or reentering back in on parole, which transitions into intercept 5 of community services, where it is parole and probation. We will take a look at all 5 slides, as well as breaking down each intercept for a development in grassroots approaches. Taking a look at what intercept 0 is, intercept 0 is community services. Providing intercept 0 is ground zero for all. This is where we can help connect individuals that may have mental health and or substance use disorders with services coming into contact before they enter in the criminal justice system. So this is our area that we will try to hit and meet with people before they get entered in, before an arrest happens, or before they're taken into hospital or jail settings. At intercept 0, this is supporting law enforcement in responding to public safety emergencies and mental health crises. What this can be is receiving dispatch calls for an individual that might be causing noise disturbances or hallucinations, and that's where our law enforcement takes place. At intercept 0, this enables diversion for treatment before an arrest takes place. So what that could mean is that if an individual is presented and they're talking with someone and they necessarily maybe haven't committed a crime, they do not need to go to jail or they do not want to go into an emergency room. They're refusing to go to the ER, but they need to talk with someone. Something needs to happen in place for that intervention. In this area, this is where community services of crisis lines and mobile response can really help those that are needing those services. At Intercept Zero, this does reduce pressure on resources of your local emergency rooms or inpatient psychiatric units for urgent but less acute mental health needs. By being able to engage with an individual that might be experiencing a crisis out in the community, we might be able to engage with them to consider and initiate engaging into mental health or substance use, or if it's a co-occurring disorder, treatment before going into the ERs or the jail system. So that way, those needing to get into those services have the availability to do so. Some key elements for diversion for Intercept Zero. There's 5 examples that we have listed here is the swarm lines and hotlines. And with that is the 988, 211. Those crisis lines can be utilized for individuals that are in crisis, needing to talk to someone that can get connected to someone confidentially that can talk with them to help connect them to services needed. A second element is a mobile crisis outreach team. As an example, that's something that I manage and oversee in our county. And what that is anyone that makes a dispatch call for a substance use crisis, mental health crisis, or a potential overdose that law enforcement will respond on, we will also dispatch out my team, which that includes a certified peer recovery coach that will also go on the scene with law enforcement, an addiction specialist, and a mental health professional will also go out to talk with the individual, see what's going on, and see if we might be able to help connect them there from services. As I mentioned in the last slide, a big factor of our goal is to help free up our beds in our ER rooms, as well as our jail settings for those that don't necessarily need to be there. Maybe they are wanting to get help, but that's how they know to get help is to come into the ER. So by us engaging out with law enforcement on 911 response calls, for those that don't necessarily need to go to an ER, have not committed a crime, so they do not need to go to jail, but we need an intervention. We need to discuss options. So we will respond out with them to help provide crisis services and see where we can navigate from there. 2 and 3 kind of ties in together. Law enforcement friendly crisis services. Many times that we will have law enforcement respond first. If they find that that is a case of where they might be benefit for the mobile response team to call out, they will notify us, and then we turn around and we will go meet outside with our law enforcement. So in our area, we work very closely with all of our first responders, law enforcement, for our mobile response. Another element for diversion is the peer-operated crisis response support and respite and substance use focused early diversion strategies. As I mentioned, I manage our mobile response team, and so my team I supervise are all peer recovery coaches with lived experience in substance use and mental health recovery. Having peers on teams, having peers respond in crisis situations definitely has made an impact on those initiating into treatment services. By them being able to talk to someone that has walked alongside their shoes has really played a big factor in being able to engage with individuals, as well as break down barriers of stigma with the community, as well as with law enforcement, of being able to understand what does a peer recovery coach do, how we help alongside our law enforcement to break down that stigma of substance use and also open the door to have that conversation for recovery. It has helped significantly in our area, being able to just combat stigma. So getting away from that term of identifying people as an addict, as someone with a substance use disorder, an individual in recovery, an individual impacted by substance misuse. It is very key for Intercept Zero of community support is having that involvement. Moving forward, taking a look at Intercept 1. Intercept 1 is our law enforcement. The way that Intercept 1 is begun, this begins when law enforcement responds to a person with a mental health or substance use disorder. This can be responding to a dispatch call 911. They get a call, say, there's a situation going on at a residence, whether it's a noise disturbance, behavioral health disturbance, law enforcement will respond. Sometimes in rural areas, I know where I live, for example, and speak with law enforcement, sometimes the law enforcement may know beforehand of knowing that address. Okay, I know this address from before. There might be substance use involvement. So this will begin by law enforcement going out to the scene and talking with the individuals. The way that Intercept 1 ends, it ends when the individual either is arrested or is diverted into treatment. And diverted into treatment can vary. That can mean diverging into immediate detox treatment or engaging into treatment with recovery support services, getting set up to get mental health services, or getting directly admitted if that is the need. Everyone's recovery will look differently, so everyone's needs will all vary each time. If law enforcement goes out, not everyone's going to need to go directly into a detox. Not everyone's going to need a direct inpatient admittance. Everyone's going to look differently. And so that diversion will play a factor into the individuals themselves. As we know, recovery is not a one-size-shoe-fits-all, so it will always vary. Intercept 1, and a way that you can help support law enforcement is by training, providing programs, policies that help behavioral health providers and law enforcement together. As mentioned, in implementing recovery support services, a big factor in a way that we help do this is by conducting crisis intervention team training, or CIT training. And what that does is that brings all entities to the party that work with an individual that responds to crisis intervention together. So that would include our law enforcement, our firefighters, your EMS, behavioral health staff, emergency room staff, your peer recovery coaches, clinical staff, dispatch, your jail, community corrections, and probation. All of us, we conducted through different trainings to bring together to really identify where gaps are in services, where are there current issues going on amongst sectors, and how can we break that down? The biggest piece to helping implement and succeeding into Intercept 1 is really that education and being able to understand from a first responder to an addiction professional what we work in every single day. For example, I signed up to work in addiction every single day. That's my jam. Our firefighters, for their whys, was to save fires. They maybe did not necessarily sign up to work in addiction, but in our area, that's something they see. So being able to have those conversations with our working colleagues to say, this is what I specialized in, this is what you specialize in. How can we work together to help those that we are serving down the road? Because we are all held to different policies as well as guidelines, ethics of what we can and cannot do. So being able to have that training and sit down and really understand what each other does helps bring that together significantly as well. Some key elements for diversion for Intercept 1 is providing dispatcher training. That can include dispatcher training on talking with individuals that are experiencing a mental health or substance use crisis, potentially an overdose, being able to walk through with an individual on the phone of how to talk through that. Because everything that we do plays a factor on the individual, whether it's face-to-face or whether it's on the phone. The way we talk with people and the way that we present ourselves is a big factor for how we can help them either initiate or refuse treatment. In addition, specialized law enforcement training. There's various trainings that are available throughout. As I mentioned, my county, we completed CIT training. There's also adult mental health first aid training that individuals can go through, as well as specialized addiction response recovery supports training for law enforcement. A third intercept is also specialized law enforcement responses. As I mentioned, with going through CIT training, we were able to, look at how can we respond to these calls to help in the long run those individuals. So knowing if there's a call that law enforcement is going on that is specifically a substance misuse related matter, calling the mobile response team immediately for us to follow right behind them. Because there will be calls that not the mobile team needs to go to for everything. However, being able to identify when can the mobile team be utilized? When is there special protocols that we need to call in these community partners to help them, to help the individuals prevent coming into the ER or the jail setting? As well as data sharing. Data sharing can vary. What that can look like is also policy sharing for organizations. Looking at Intercept 1, law enforcement, a big data sharing that we were able to fix just in my area is through our CIT training, our local jails had a varying policy for individuals for blood alcohol than our local ER did. So we were able to bring both data sharing together, look at both policies, and able to revise those so that way our local ER was matching and would not discharge someone out with a blood alcohol that differed from the jail. An example that fixed this was many times patients would get discharged back. The jail could not accept them on that level, but there was a disconnect from organizations. Neither knew their policies of what accepting was, so being able to work together, sit down together, helped fix that so that essentially we're on the same page working together of sending individuals there. That way, it's not a case of they come back to us in the ER and now we're working back at square zero. So being able to share that data of this is what our policies are, or this is what we're seeing being brought in, what is happening to be brought in, and what are some prevention or intervention strategies to implement to help fix this for Intercept 1. Taking a look at Intercept 2, Intercept 2 is the initial detention or initial court hearings. For this would involve individuals that have a mental health or substance use disorder that have been arrested and are going through the intake and booking an initial hearing with a judge or magistrate. So at this Intercept level, individuals have been arrested. There was a crime that was charged, and they were in the jail having to attend their first hearing. With Intercept 2, at the court hearings, there's policies that allow bonds to, this can help support policies that allows bonds to set to enable diversion to community-based treatment and or services. This also can include post-booking release programs that reroute individuals into community-based programs. So when you're looking at the initial in court hearings, this can look at possibly getting them into treatment court, or if you have an individual that was arrested with a severe mental illness that really needs some mental health services or medication that they may or may not be able to have access to in the jail, of getting them there to connect them to those services that they need at their initial detention and court hearings. Some key elements for diversion for Intercept 2 is being able to screen for mental health and substance use disorders. So when individuals are brought into the booking, is being able to provide a standard screening to identify substance use or mental health disorders. In addition, as well as data matching, as with key intercept for Intercept 1, being able to share data and see who keeps coming in, what is happening, and seeing if there's data to identify what is the need that's not being met right here. How can we meet this need? And with that, also looking into the pretrial supervision or diversion services, whether this might be an individual on pretrial getting to go into a mental health treatment or a substance use residential 28-day treatment program and then come back before court. So that way they're able to get those services that they're needing and taken care of before they are attending their courts, as well as post-booking release. If individuals are released, of being able to provide them resources or provide them, getting them connected to something on the outside as whenever they are getting released, so that they aren't getting lost in the cracks, or they're not released and then we won't see them again until they're back in the jail setting or back in the ER. So helping those helping them to divert them back into the community to set them up to succeed. Taking a look at Intercept 3, this is our jail and our court settings. And so this would involve individuals that do have a mental health or substance use disorder that are held in jail before their trials. With Intercept 3, this can include court-based diversion programs. This allows the criminal charges to be resolved while taking care of the defendant's behavioral health needs in the community. In addition, this can also include services that prevent the worsening of a person's mental health or substance use while incarcerated. As I mentioned in Intercept 2, with Intercept 3, being able to have the substance use screens to screen individuals that are incarcerated and see if they do have a mental health or substance use or potential co-occurring disorder that needs to be addressed while they are incarcerated. For an individual with a severe mental illness and SMI, if they are in the jail setting and they're not taking medication that is needed for their mental illness, this can cause them to worsen before they are going to courts. So being able to advocate in the jail setting and with the courts to get individuals to treatment before going to court, where they can send them on a furlough order to go to a 28-day treatment or go into detox 28-day and come back, or to seek mental health services. That way, we're helping support the individuals that are needing this, being able to work on themselves, work on their mental health and their addiction and recovery before going into court. For individuals that are not having medication, that need medication in order to thrive, this can worsen an individual's mental health. So if we have individuals presented in the jail that are not getting the services that they're needing, they are worsening and sitting there versus being able to help them or engage with them. Whether there's programs that they can connect to help work on their mental health and recovery before going back into court, before they get tried. Because all the courts vary, different counties. An individual could be sitting in the jail for 6 months or a year before they have their hearing. And so this can significantly decline one's mental health if they're not getting their services within that time frame, waiting for their hearing. So key elements for Intercept 3 is treatment courts for those that are high risk or high need individuals. And that could be a recovery court, family court, drug court. So an individual that may have a severe mental illness or a high risk substance use disorder that is really needing assistance clinically, this can help them advocate to get into services as well as being followed while still under the judicial system, but addressing and working on themselves, as well as alternatives to prosecution programming, jail-based programming, and healthcare services. So that can vary in areas. Some jails have programs within their jail systems. Some bring in services. So if that is providing psychiatric care, that is someone coming into the jail weekly or however often based upon the jail size and individuals in needing services, as well as nursing and as well as recovery support services. So if there's any programming occurring in the jails that individuals could attend if they are able to, as well as partnerships with community-based providers, mental health and substance use treatment. With that, having your local mental health services, having your local providers being able to come in or meet with the individuals that are needing services. Some jails do have mental health jail liaisons or diversion clinicians that can help with diversion. What they can do is help go into the jail and complete these assessments, whether it's a standardized mental health and addiction assessment for the courts to identify what the individual's level of needs for care are, as well as collaboration with the Veterans Justice Outreach. Many individuals within the jail have many needs, many services that will vary. In jail settings, it can vary from area to area. However, we do see many, even in our local area, that we're veterans. So helping to connect with outreach services that can work with them while incarcerated, but also while they are on the outside or prior to even engaging with incarceration to help prevent incarceration is key for Intercept 3. As we're seeing in areas, the mental health jail liaisons and clinicians, many times the jails will bring in local providers. If they do not have the capability to hire on staff, they can bring in and have that collaboration. And as shared earlier, that is where it's key and very crucial for data sharing of knowing what their agreements are, but being able to collaborate together. If there's an incarcerated individual that does have a mental health provider that they're following with, to communicate so that way they can communicate, come inside the jail setting to meet with that individual. As clients, we've had, and we know sometimes connecting to a new therapist or to a new provider can be very hard for clients, or they don't like to. I've already shared my whole story with someone. Why do I have to rehash this back out? That can also provide more re-traumatization to the individual. So by being able to have a partnership with the local mental health and addiction providers, that can break down that re-traumatization for individuals by being able to connect them directly to who they are meeting and working with. They know that individual, have rapport built up with them, and that can help strengthen the collaboration within the jail setting and the mental health setting for that individual to meet the care and services that they are needing. Taking a look at Intercept 4 is our re-entry phase. What this is it provides transition planning and support to individuals with mental health and or substance use disorder that are re-entering and returning to the community after incarceration from jail or in prison. Re-entry does ensure people that have workable plans to provide a seamless access to their medication, treatment, housing, healthcare coverage, and services from the moment of release and throughout their re-entry. So for many, when they get into re-entry, there are many services now that help provide them that services. So when they walk out the door, they're set up for success. Versus if there is no re-entry care planning happening, those individuals, especially if they were ones that were sitting possibly pre-COVID pandemic into today, they're walking into a completely new society, a new world. It's very changing. So having them prepared will set them up to succeed versus setting them up to walk right back into the doors. Re-entry is very key. Some intercepts, key elements for diversion for re-entry on Intercept 4 is transition planning by the jail or by in-reach providers. Also, this includes medication and prescription access upon release from the jail or prisons. In addition, this is warm handoffs from corrections to providers to increase engagement in services by the individual. Taking a look at their benefits and healthcare coverage immediately following or upon release, peer support services, and re-entry coalition participation. So taking a look into re-entry transition planning, this can occur by the jail or by in-reach providers of helping planning what their transition plans are. So if an individual is going on to parole or going into corrections, probation for reporting, of being able to set those services up for the individual prior. Sometimes that can take a look at where is their housing? Do they have housing? Do we have a home that they can go to if they are needing a home base, or if they have a home? Also taking a look at if the individuals has a social support system. Many times in areas, there'll be individuals that are incarcerated that might not even be from that county and or state. And so they have no social support, have no family, have no friends. And so their social support system is very limited. Being able to identify those and what are the needs and services that we can help get them. In addition is medication and prescription access. Some individuals may be prescribed a certain medication that they have to take that they possibly did not have access to while incarcerated, or it's a prescription that's needing refilled upon re-entry. So being able to identify those and get those individuals help set up, as well as setting up their insurance. So when individuals are incarcerated, their insurance stops. So when someone is on re-entry, being able to have someone to provide the benefits and healthcare coverage being reinstated, or if it's an individual that did not have insurance, helping getting them set up with Medicaid and state insurance, so that way it is active upon release so that they can engage in getting their prescriptions filled. Peer support services. Peer support services is very key on a re-entry part. I'll go more into depth about our re-entry here in the next few slides, but touching on it for diversion, having peer supports that are housed in the jail, whether it's a forensic peer recovery coach, can help provide that navigation and re-entry services. Whether it's conducting a warm handoff to a peer recovery coach in the community that can help walk alongside that individual as they're getting connected back from reincarceration. And whether that is attending their probation meetings, going to community corrections, helping them get to their pharmacy and to their mental health provider to get all of those set up. Because for an individual that was incarcerated going back into the community that is justice involved, they have a lot of responsibilities that they have to meet. They have to make sure they are attending their meetings, attending screens, and following everything that was written in for court that they have to meet. And for many of them, that also entails getting a job, finding housing. So all of this to-do list that is overwhelming and can be very overwhelming for individuals incarcerated. Having peer supports that can help walk alongside them to help that have been in similar shoes and navigating the system. Whether it's a rural or urban area, being able to find the insurance office, it can be a challenge. You might not know where it's at. And individuals that were incarcerated might not have a smartphone or a telephone to be able to find these services or to call to get set up. So being able to provide peer support is key to helping those individuals to have that support and have that hope that they can walk through this and ensure that they're meeting what is needed so that they can thrive. And with the Reentry Coalition participation, that is bringing all of your providers and entities together that may work with individuals that were or are incarcerated to identify reentry needs, to identify what they can do to help strengthen reentry for those in the community, whether it's providing more support face-to-face, providing more resources of helping them know what their next steps are. Taking a look at the final intercept, this is Intercept 5. Intercept 5 is community corrections. This involves individuals that have mental health and/or substance use disorders that are under community corrections supervision. This also strengthens the knowledge and ability of community corrections officers to serve people with mental health and/or substance use disorders. It addresses the individual's risk and needs, and it supports partnerships between the criminal justice agencies and community-based behavioral health, mental health, and/or social service programs. Taking a look at Intercept 5 community corrections, the key elements for diversion is providing behavioral health training for all community corrections officers. That can include CIT training, adult mental health first aid training, or any specific training to community corrections officers being able to identify and understand behavioral health and substance use concerns and needs. In addition, having specialized caseloads for people with mental health and substance use disorders. That could vary from the community correction services. There might, I have seen where there's case managers that are specifically that would work with individuals that have high risk mental health needs, as they are more trained in mental health services, as well as individuals that may be more specifically trained to understanding addiction that can work with those that identify with a substance use disorder or co-occurring disorder. By having staff that are specialized to work with those needs, that helps being able to identify and best serve those that we are serving in the community. Having an individual specialized in mental health and/or addiction treatment, working with those individuals, they'll be able to help provide education with them and help conduct them more into services they may need. In addition, a key element is community partnerships. With that, case managers and community corrections staff, they may have individuals that might benefit from connecting with community partnerships for services that may be needed. There might have individuals that would benefit from having a peer recovery coach, and so having the partnership to connect with a peer is key, as well as having partnerships for mental health services, but also even domestic violence services, that anything the individuals can need. Having those partnerships and knowing who to call or who to get connected with is very key with community corrections. In addition, medication-assisted treatment, you might have also seen this around as medication-assisted recovery, MAT for short. Medication-assisted treatment is a form of recovery that is for individuals that may need medication into their recovery. With medication-assisted treatment, there has to be an understanding of the medications, education, and awareness. But also in a community corrections setting, the individuals have to ensure that's something that they are able to be on in order to be on community corrections. And so having an awareness of MAT, having the resources and supports, but also having providers locally that offer MAT to help with the community partnerships is very key for community corrections. And this Final element is also access to recovery supports. As I mentioned earlier, in community partnerships, having recovery supports access in community correction settings is key. As I shared earlier, with different entities, it is a benefit to have those that are specialized in that area to help alongside those that are specialized in the justice setting or in the community corrections setting. Being able to connect the clients that are needing that to recovery supports, it can help promote and increase the engagement of services as well as initiation into services. And it can also promote and increase the individual's likeliness to engage and maintain into treatment if they're having someone that they can help walk alongside of while they're navigating. So taking a look at the past 5 at all intercepts 0 through 5, we're going to kind of take a look at discussing how we are able to utilize intercepts 0 through 5 with using a grassroots implementation of recovery supports in rural communities. Taking a look at peer recovery support, it is a vital element in addressing substance use disorder in rural communities. Having peer support helps individuals that have that lived experience that can break through the barriers and those of our clinical professionals that we are not able to break through. And the role of a peer recovery coach is based upon that lived experience, that me too, I've been in a similar shoes, I've walked down this road with you, versus as a therapist in a clinical hat, there's confidentiality. Sharing that there's a very fine line of confidentiality. So it's definitely vital in addressing rural communities of having that person that they have as that support. Taking a look at implementing recovery supports in rural communities, this is a timeline specifically of the area in which I serve at Grassroots implementation. Back in November of 2019, the Sequential Intercept Model SIM grant had started peer recovery coaching in Daviess County Community Corrections in Indiana. Through this, that has started providing a peer recovery coach in community corrections to help engage with individuals that were potentially in active addiction, newly in recovery, that are involved with the justice system, to connect with a peer and walk alongside them as they're navigating through. Further along, Daviess County did receive an additional grant through the HRSA Health Resources and Service Administration to continue the peer recovery services program after the end of the SIM grant. In addition, this also added on 2 part-time peer recovery coaches through community corrections. At this time, they had expanded and provided a peer on call into our hospital setting, and within 15 months, he had seen 135 patients in our ER that were identified with substance misuse or came in on an overdose that was needing connected to services. And so from that, our hospital had created a partnership with community corrections to provide peer support in the ER and in the ICU strictly to help those that present with an overdose or substance misuse, with a peer recovery coach to have a discussion about initiating recovery services. Part of the program it's all voluntarily based. So individuals have the option if they would like to talk with peer or if they would not like to. From that and from the continued success in 2021, Daviess County did receive the State Opioid Response 2 grant, which expanded the peer recovery services program in the hospital and the community-based setting. With that is where I kind of came into play. We began our mobile integrated response system back in 2021 officially, of having peers, a full-time staff here in the hospital that respond to anyone presenting in the ER or in the hospital with an overdose or substance misuse, as well as in our community and in our jail setting. So if anyone that was presented into the jail on arrest had a substance misuse release, we would connect with them, and we would also connect in the community standpoint and then with our local law enforcement out in the community. So we were hitting all intercepts slowly and surely and expanding into our jail setting quickly in the spring of 2022. Taking a look at the Grassroots implementation, focusing on Intercept 1. As I mentioned earlier, spring and summer of 2022, all first responder personnel of Daviess County did complete crisis intervention team training together. I can tell you transparently, it was, and working in a systems level of addressing substance use it's baby steps. being able to bring all entities together of different organizations to understand that we all have the same concern, we all are addressing the same issue, but we're all doing it differently. With CIT training, we were able to sit everyone down together and provide education of standard substance misuse education, mental health education to our first responders and law enforcement. But then also on the law enforcement side, we were able to understand education of an emergency detainment order, immediate detention orders, how the process for law enforcement to come to our ER works and how it works for our hospital staff. Being able to bring everyone into that room and essentially switch shoes really helped gauge and break down those barriers of, well, this system has worked like this for years. Transparently, I can add, jumping in that training, I was a newer leader. And so there was just stigma from organizations working in silos because concerns and issues were never getting addressed. They would speak of them, but no one was taking the action to fix them. So with that, we were able to make a lot of quick fixes. Thankfully, we were able to bring in our judge to provide us a walkthrough of what an ED, emergency detention, immediate detention order is, how it looks, and how it gets broken down. We were able to change the verbiage in that to help nursing and law enforcement be able to conduct that warm handoff in our ER setting to ensure that those paperwork and processes are getting completed in a timely manner, as well as with our behavioral health groups. Many things that we found in this training was that a lot of our law enforcement and our behavioral health and all groups just assumed the other organizations could do that. Well, law enforcement has this, they can do that. We were able to sit down and say, no, you cannot. This is what we do. This is our scope. This is how we can fix and work alongside each other. As with our firefighters and our first responders, some of them did have stigma against addiction and just kind of jaded, and that we were able to address. We had a panel during the CIT training where my team was able to share their lived experiences from while they were in addiction and entering into recovery of stigma they faced from first responders because they were perceived as an addict, and how where they're at now as working peer professionals and seeing them in a professional setting. So being able to have those conversations face to face of what you say when you respond to a call, how you are acting significantly impacts someone was very key. From this training, I was able to share as with peers. Peers are based upon their lived experience, and myself included as a certified peer mental health recovery. I talked with our first responders about how they responded for a call when I was a kid, impacted me to do this work I do today. And they were still working and being able to have those conversations, but we could break down the stigma with those that are directly frontline working with addiction was huge. And from this as well, expanding with our mobile response, our local dispatch office. Now, my team, we are on call 24/7, 365 for the entire county. Our entire county dispatch receives our on-call schedule, as well as our hospital staff. And local community partners, so our local schools. But if someone calls into 911 or into 211 in crisis, they automatically will contact my group on call. So they know who's on call, they know who to get a hold of, will respond onto that scene. An additional piece to, it was just a quick little easy fix with law enforcement was I provided them brochures to carry around, and generating a business card size front and back infographic card was a huge game changer to our law enforcement. It was like Christmas. They said it was a lot easier to carry because it was a lot more smaller than the brochures. It would not get smashed up. They could give those out on the calls. So all of our law officers actually carry all of our on-call infographic cards. They have our direct calls on everything. So any call they go out to, they provide that to clients. So we were able to make those changes within our communities, just within the Intercepts 0 and 1 points. In addition, as I mentioned earlier, our judge did revise our IDO and EDOs to be a bit more clear. He also came into our hospital and provided education for our emergency room staff, our nursing staff, and our behavioral health social work staff to go through what an IDO is, what an EDO is, and what the importance of is to have that communication and documentation and warm handoff from law enforcement to the ER, from ER to social work within those settings. Because those orders are very timely and you're working on a clock of when those get started. In addition, while we completed CIT training, we had a day of not necessarily working in the roles, but shadowing alongside different departments. So I had all of our law enforcement come and see our peer recovery services department, as well as our ER and our behavioral health groups. So they see on our day-to-day what we do and how we work and our workflows. So that way, when they call us, they are well aware of how fast we can turn and respond to a situation. In addition, we were able to conduct ride-alongs, so that way my staff ride along now with our EMS. Our local EMS is actually part of our hospital, housed here in the hospital, and so my team is able to ride along with law officers and EMS on calls. So we do bi-monthly ride-alongs to where they will just go a shift right along with the staff, so that way they're making rapport with our staff. They know who EMSs are, and as well as peer recovery, but then being able to be trained on how they respond in crisis situations. From this, just having that firsthand exposure provides my team, and as well as other teams, ways to make process improvement and to fix those protocols. Because something that we can see is we can make policies that work great and perfect, but in the actual crisis response, when someone is actively overdosing or someone is actively in a crisis, that policy and protocol may not work. So we're always looking at that of how we can fix it and make it a lot easier. Something we also do that was implemented in down the road was also debriefing of crisis intervention. Unfortunately, in our area this last year, we had experienced 4 teenagers that had 2 had died by suicide, 2 had died from overdose related causes. That was significantly traumatic for our first responders. And so now we have actually set up a debriefing kind of coalition support group for all first responders that they can come in end of each week and have discussion on if they did respond to a call. That was a lot, and they need to talk to someone of having that, because we did not have that available. A reason it was started was the first firefighter and told me directly, we respond call to call to call to call. We go, we put out a fire, we're out to the next one. We do not know a follow-up of what happened. And so that is a big piece of where my team of the peers can help that follow-up of, did that person survive an overdose? Is that person are they still okay? Because some of our firefighters transparently said it keeps me up not knowing how they were and if they were okay, and I can't take that home with me, and so I don't know what to do about it. So we were able to also, not only for our clients, but for those first frontline staff, provide and implement in an intervention support for those, because seeing traumatic events nonstop can take a toll if we do not have healthy means to process it. Taking a look at Intercept 2, as mentioned earlier, the state opioid response grant did expand peer recovery coaching across multi-sectors. With the Source 2 grant originally starting, we were to have one individual as a peer recovery coach that would work in our local jail as a reentry navigator. Then we would also have 3 full-time peer recovery coaches up at the hospital to work in the hospital community response system. Early in the spring of 2021, Daviess County was actually selected to be one of 5 pilot counties for the Integrated Reentry and Correctional Supports IRACS program. And so that actually absorbed our reentry peer and brought in a full team of peers into our jail setting, which are still here today. With that is expanded, and so today we actually have 4 full-time forensic peer recovery coaches in the jail, 1 full-time peer recovery coach supervisor, and we are about to expand and add on an additional forensic peer recovery coach to facilitate matrix groups in the jail and in the community-based setting. So it is expanded entirely. This is also something the state of Indiana is working on, hopefully having all 92 counties or all counties that have a jail have an IRACS program in them. What the IRACS program is they advocate within the criminal justice courts for clients and for appropriate recovery appropriate recovery resources in the community, such as sober living, treatment facilities, work release, and medication-assisted treatment. So we have peers in the jail that will conduct assessments for individuals to see if they are appropriate to work with peer recovery coaching in the jail setting, as well as a peer that facilitates groups. So now within our jail system, incarcerated individuals can attend wellness recovery action planning wrap support groups that is facilitated 2 days a week. There is a men and women's group option, as well as intensive outpatient programming IOP matrix. It is ran in our jail setting, and so individuals are able to have IOP and wrap support groups, as well as we do have a pod in our jail for RARE, which is a recovery support faith-based pathway programming that individuals, not all individuals, but select individuals can attend in as well for services. Our IREX team has done strides in our jail to help individuals be set up for success upon release and on re-entry. Looking at Intercept 3, kind of tying in as Grassroots. As I had mentioned, March of 2022, we had hired in a peer to do re-entry, which quickly merged into our IREX program. Our re-entry peer would provide a warm handoff to the community team for individuals on re-entry. And so, as I mentioned, there are a lot of recovery support groups and intake assessments completed in the jail. A big key of our IRACs and our community mobile response team is that our re-entry peer will help individuals follow alongside for 7, 14, and 30-day follow-up when the individual is released to make sure that they were not falling through the cracks. So when an individual gets released, and we're still actively working on this part here too, of making sure we can meet before they're released from the jail, but they will meet with the community peer as well as their IRACS peer to have an introduction, put a face to a name of who their community peer is that they can work with alongside when they get released. Something new that we've been able to implement now is that when individuals are immediately released and have to report to community corrections or to their probation, the community peer and IRACS peer is actually walking alongside the individual to these meetings. We are helping guide them there, meet their probation officer, meet their case manager, ensure that they are understanding what is their requirements from them of being on reporting, helping getting them connected to their mental health facilities, as well as getting them connected to resources that they need. All individuals that do get released from Daviess County Jail are provided Narcan upon release. Our sheriff approved that spring of last year. And so anyone that is bonded out of our jail is sent with Narcan, as well as a packet of resources of local information for mental health, addiction support, as well as housing and local resources of where to go and who I get connected with. We do have a peer that does navigation on the IRACS team. So all individuals, if they had insurance before incarceration, are leaving our jail with activated insurance, or they are having insurance applied upon release. So now that they are released, they have activated insurance, and we also ensure that all individuals are provided with their ID or driver's license and or birth certificate upon release if they do not have that. And so by the time they're getting on reentry, we are ensuring that they have their ID, a driver's license, social security card, birth certificate, and they are also connected to a peer on the community to help walk alongside them as they are engaging back in the community. Looking at Intercept 4 with reentry, parts of Grassroots implementation. This is a piece we're always improving and always looking at, but our reentry peer conducts a warm handoff with our client and community peer upon reentry. And with that, the IRACS peer that is on reentry will connect to the client and on 7, 14, and 30 days upon release to ensure that they are supported upon release. And with that, we're making sure they're connected to services. Something that is to note in this area, though, is with peer recovery coaching, it is a voluntarily based program. So if the individual that is incarcerated does not want to work with a peer, we cannot force them to do so. So they will not be forced to engage with us. And with those 7 and 14 and 30-day follow-ups, if they refuse to connect with us on the community side, the IRACS team will still call and follow up with them just to ensure that they are meeting those needs and that they're anything that they're needing is being taken care of before, while they're on reentry. I can say that it's not as seamless. It's always getting worked on. We're always improving this, as sometimes we do have clients or individuals that are on reentry that we cannot find, that do not want to engage upon release, or if they were bonded out and did not get that face-to-face connection and introduction, the reluctancy to engage in services is a lot higher. Having that face-to-face does go a very long way of breaking down stigma, breaking down concerns for the individual of who am I meeting with. So we really strive to make sure we can meet with them face-to-face before they're back in the community, so that way we can hopefully follow alongside them further on down the road. And with this, peers, we navigate attending meetings with community corrections and probation to ensure clients are understanding their guidelines. So when they have an introductory meeting with community corrections, our community team and our IRACS team are going with the individual to that first meeting to introduce themselves, know who they are from the community side, as well as ensuring they know everything that is asked of them for reporting, that they understand, and if they have any questions, to help work through that. With this, we were able to establish 2 now monthly. My team, we meet every month with community corrections and with probation to go through our clients that we have on active caseloads, to really discuss the client's treatment plan of action and ensure that it is the best plan of action for that individual. A big role of the peers and with these team meetings and with implementation is ensuring advocacy and education. Those are the top 2 things that are going to succeed with implementing. As I mentioned earlier, with having community corrections staff that might be specialized in mental health or substance use education, having peers with that experience can also help provide insight to our case managers of how things can work the certain ways. From our team meetings, we've had case managers being able to talk with the peers directly, and my team communicate with them of saying, this is what they can do as a great option. Or, for example, if my team has concerns about an individual, we can bring that to community corrections and say, this is the concerns we have from what we're seeing. How can we best help this individual? And so from that, we've been able to help individuals, instead of getting revoked, having a PTR, getting them to have that conversation to engage into treatment before they have to get revoked into services. And it's also provided reducing stigma with community partners on addiction as well too. In a rural community, as I shared earlier, sometimes family connections is a benefit of having the family social support. You know your family, you know you can help them. But on the other flip side of things, when it's an addiction, when you have a family that's been impacted by substance use disorder and all of them are in active addiction, there can be stigma that is perceived through community partners. And where we've seen, well, the family is in active addiction, how can we have hope for one when everybody else is still in active addiction? So being able to advocate and really break down those barriers for the individuals is something key that we've been able to do with, by breaking those gaps down and being able to work alongside each other and not siloed. Even though we're a different organization, we can go to you, they can come to us, and we can help better serve the individuals that we are serving. As I mentioned earlier, all individuals from our jail do leave with a copy of their birth certificate, driver's license, or ID, and their insurance is reactivated, as well as Narcan upon release. Taking a look into Intercept 5 of the Grassroots implementation, as I shared, my community team, we engage with clients in the community and attend care team meetings and assist clients in navigating the system. As my team works in responding at the hospital and the community and jail setting, we attend care team meetings with our hospital staff as well as our judicial teams as needed. When patients are brought into the hospital and they go through the ER and are admitted, our hospital does care team conferences every day that our team is involved in. If we have a patient that is potentially in need of services or that we would be consulted on, my team is involved in the care team. So we meet with our hospitalists, our doctors, our case managers, nursing, as well as our social works department, our dietary, and our PT, OT to be involved in the care team. So we're advocating for the patients and being able to address if there is a need for a patient to stay an extra day to get into treatment, or that there's needs at home that are concerns, so we should not be discharging them, being able to advocate at a higher level. It's really impacted and really been positive for our hospital setting. As I shared earlier, you don't know what you don't know. It's a strong line I use in a lot of community meetings we have, is with the services that my team sees, is we're walking alongside individuals in their recovery. And so we are the boots on the ground, and we do break those barriers of being able to provide transportation and access to their meetings or getting them into treatment. And so having that lived experience, sometimes my team sees a different side of the clients that's very key to being able to help in communicating with their judicial partners or with their clinical care team to help meet those needs. As I shared earlier, having an individual being to reshare their story can be re-traumatizing. And so having to ask this individual the same question 5 times, by the 3rd person, you might get kicked out of that room. And so it's very important, by having those that are already there have that discussion so they know that we don't have to re-traumatize them and address these needs appropriately. With our community team, we help individuals assist in finding housing, navigating the housing application, obtain housing. We also assist with employment, whether it is seeking jobs, finding job applications, connecting to Work One or Premier Staffing, as well as employment coaching. Sometimes we have clients that are illiterate or have never made a resume. They don't know how to type, don't know where to start. So we start there, and we are building up with them, getting them connected into work readiness classes, job trainings, certificate programs, really whatever the individual's interested needs are. We also help engage in the recovery community. As I've shared, we walk alongside the individuals as they navigate their pathways to recovery. With peer recovery coaching, we do not do anything for individuals that they can do themselves. We do not diagnose substance use disorders or treat substance use disorders, and we are non-clinical. So we help support them in those capacities that we are able to support. We do acknowledge all pathways to recovery, and that is where, as peers implementing into the community, we help provide education on medication-assisted treatment, and also with community partners on the various signs of addiction and signs of overdose, and how you can connect them to services that is needed. Very big in our judicial system. They will have specific guidelines they have to meet in order to be finished, whether that is attending an IOP program, attending so many meetings a month, or visiting with their mental health provider. So we're also able to advocate to our judicial partners of the need for more recovery supports, of access for individuals to have that time to focus on their health and focus on their wellness and their spirituality, of getting them out in the recovery community to engage more, to help them get set up for success and support them in their own pathways to recovery. So as I mentioned, everyone's will look a bit differently. Not everyone's going to recover the same way. We might have someone that does need medication-assisted treatment versus someone that may not need that. They may just benefit from going into residential treatment and then transition to sober living and connecting with a peer afterwards. So being able to know what the needs are and the varying needs of recovery is very key to helping support and implementing recovery support in communities. Overall, taking a look at a few key takeaways from today is regardless of the area an individual lives in, there's a multitude of barriers to addressing substance use, regardless of their geographic location of the individual. Looking at implementing into peer recovery support services, it is vital for addressing substance use disorder in communities. And every community will have varying needs in addressing substance use disorder, but keeping your community involved is the key. By speaking to community members and having sure that they have a voice and a spot at the table for these conversations is going to go a long way in implementing and addressing substance misuse. Having their voices heard is huge. So involving the community is key. And also it requires involvement from everyone to combat substance use disorder. As I've shared, I work in a multi-sector setting, so I'm working in the healthcare, criminal justice, various settings on a day-to-day basis. And with that, it has to involve and understand that everyone has different needs and is trained differently, but we're all working to address the same matter at the end of the day. Being able to bring those differences together and fix them is how we can address substance misuse as a whole. As I shared, every organization operates differently. Being able to understand that and work together, it not only will benefit us, but it will benefit those that we are serving down the road in the long run. Another big key takeaway I have is that implementing and emphasizing evidence-based practices is essential in addressing substance misuse disorder. We also need to develop innovative and local responses to close the treatment gaps and effectively reach treatment individuals with substance use disorder. We need to be able to look at the communities and see what do you have, what is available, whether it's conducting a community health improvement plan, a CHIP plan, identifying what do you actively have, what is not here, how can we get that here, is how we will help benefit those living in our communities. Because as I said, you don't know what you don't know. So if for someone that might not work in addiction or in mental health, they may not know where to start. And I've had many conversations where individuals weren't even aware that in our area, detox facility is an hour away. And so having those conversations, getting out there and discussing this is the key into addressing substance use and being able to make those change in your communities. I'm out here on my final slide. I did provide my work email. If you do have any questions or anything in the chat, I'd be happy to answer them. As I see we've got about a few extra minutes here, I'd be happy to answer any discussion or follow-up questions before we wrap up. Absolutely, you guys are super welcome. If there is any questions, I'd be happy to answer them in the chat. If there are not any questions, I'll be happy to hand it back over to Rob, so that way we can wrap up today. And I appreciate all of you jumping on. As I said, I'm happy to answer any questions, or if there's any follow-up information, please feel free to send me an email, reach out. I'd be happy to answer more or talk further in depth about anything that we've covered over here today.
All right, thank you so much, Shaina. I'll keep watching the chat. I haven't seen any questions come through as of yet, but I'll keep watching over that. In the meantime, I will switch it over to our conclusion. I want to say thank you, Shaina, very much for the information that you shared today. Thank you for your time and your preparation. Getting a lot of good feedback in the chat, so thank you so much for your time. We have included Shaina's contact information so that you can contact her with any further questions. Please note a few business items before we conclude today. For the first, I am posting a link to the evaluation in the chat. Additionally, when I conclude today's webinar, your web browser will ask you if you would like to be redirected to a website. That is not spam, that is WebEx trying to redirect you to the survey automatically. So please don't close out of your web browser. It will come up and say WebEx is trying to redirect you. Once you access that survey, you will be prompted to sign in or register to complete the evaluation. You can register as a visitor at no cost. You may do so by clicking haven't registered yet. You must use the same email address you used when you registered for today's webinar when you set up your profile in FATA system. This is the only way to connect your attendance and your profile. After you register or sign in, you will be directed onward to the evaluation. You will get a second opportunity to complete the evaluation through a follow-up email later today. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the professional information section of your profile. Please remember that the evaluation will close at the end of the day on Friday, March 29th, 2024. If you experience difficulty logging into your account or accessing the survey, you may contact FADA's team either by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org before March 29th, 2024. As a reminder, we do not email statements of credit. Instead, after we verify your attendance and the completion of the evaluation, a statement of credit will be posted as a journal entry on your profile within 30 business days after the evaluation closes. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and the PowerPoint, visit www.fada.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again, Shaina, for your time and your information. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone, and please hold for the evaluation.